pleasure of having a distinguished panel of speakers. We're going to initiate that with Dr. Alistair Kent, who is the Director of Genetic Alliance at the UK, formerly Genetic Interest Group, whose aim is to improve the lives of people affected by genetic conditions by ensuring that high-quality services and information are available to all of them and to all who need them. Prior to joining Genetic Alliance UK, Alistair worked for a number of voluntary organizations on issues concerning policy, service development, and disabled people. We're going to have a 20 minutes presentation of each speaker, and then at the end, we'll have time for questions and answers. So please welcome Dr. Alistair.
Thank you very much. Thank you. Right. Right. Well, good evening, everybody. I'm delighted to be here, back in Alexandria. This is, I think, the fourth BioVision meeting that I've attended, and it's a great pleasure to be here with you again. I'd like to thank the organisers for giving me the opportunity, and also for giving me an interesting topic to think about. I should say right from the start that this is not a technical presentation like many of the others that you may have listened to during the course of the last day or so, because I'm not a medical doctor, I'm not a researcher, I don't work for industry, I don't make things. What I am is a patient advocate. What I do, as our chairman has introduced, is to try and present the case for sustainable intervention in biomedical research and development, and for the translation of that into things that will benefit people living with life-limiting diseases. So, and what I wanted to do really, just to contextualize the remarks that I'm going to make, is just think about the pace of change. You know, 13.6 billion years ago, we had the Big Bang, give or take a few nanoseconds. About 4 billion years ago, the Earth was formed, and about 50,000 years ago, Homo sapiens put his head above the edge of the Olduvai Gorge in the Rift Valley in Africa and discovered that he was suffering from life-limiting diseases. But the cause of those diseases, the opportunity to intervene, remained a complete mystery. The understanding of modern medicine began, perhaps you can pick a random point, I choose 500 years ago, when Vesalius, who's been described as the father of modern anatomy, at least in Europe, I no doubt that you could find a suitable figure from the Arab world who could make a similar claim, began to look at the structure of the body and began to think about how that might frame the nature of illness and ill health. And then 150 years ago, Gregor Mendel, the monk in the Czech Republic, discovered the basic concepts of genetics. About 60 years ago, in 1953, Watson and Crick wandered into the Eagle, a pub in Bennett Street in Cambridge, and announced to the assembled drinkers there that they'd basically worked out the structure of DNA. Then 14 years ago, there was the first sequencing of the human genome, a magnificent scientific effort that cost billions of dollars and took hundreds and thousands of science years in order to bring it about. Today, we're approaching, if we haven't already got, the ability to sequence a human genome for about $1,000 and to do it more or less overnight or in the space of a couple of days. And tomorrow, who knows? But the pace of change is accelerating all the time. And we've struggled to accommodate that new knowledge in ways that are sensible and usable. So the size of the challenge that faces us in healthcare is immense. There's a genetic component to almost all common complex diseases. But in addition to those common diseases, there are at least 6,000, more by the day, rare diseases, 80% or more of which have got a genetic cause. And most of those genetic rare diseases are pediatric in origin. So they cause a huge amount of childhood morbidity and mortality. And think about what that means for the families who are affected. Think about the aspirations that you have for your children, if you have any, or that for the children you might hope to have if you haven't any of your own. Think about the expectations. Nobody wakes up with a child and thinks, I want them to be anything less than perfect, although our definition of perfect varies according to how we see that. Nobody says it would be an interesting idea to have a child with a life-limiting genetic disease about which nothing can be done. And although individually these diseases might be rare, they affect 1 in 17 of the population, and very few of them, despite that incredible advance in our understanding of the basic mechanisms of our biology, have any effective interventions available to them. So for healthcare systems, and as well as for families and for broader society, the idea of rare diseases is that although they might individually be rare, they're not uncommon, and they present a significant public health challenge as well as a human tragedy for those who are affected. Now, genome sequencing has opened up possibilities that we have never had before. You know, we've got a trajectory of diagnosis. If you think back to, you know, Homo sapiens 50,000 years ago, looking over the edge of the Olduvai Gorge and saying, well, blow me, I've got muscular dystrophy or cystic fibrosis or thalassemia or sickle cell disease or something. That's really spoiled my day. I wonder where that came from. You know, we've gone from the business of diagnosing through examining the trajectory of the stars in the heavens to the resolution of basic biological flaws at the molecular level. And that understanding of those basic biological pathways creates the opportunity for us to do something about it, to intervene. And we're standing as we speak on the edge of the era of, and the buzzword changes according to who you're talking to, but of personalized or stratified or precision medicine. You know, that's the right medicine for the right person at the right time in the right dose. You know, delivered in such a way that you can maximize the health gain from providing the intervention and minimize the risk of causing serious adverse events, and also reduce the waste by stopping giving people medicines that are unlikely to help them and might do them significant harm. Now, the question I want to ask you is this reality, or is it just rhetoric? Is it just a kind of nice phrase that gives us all a comfy feeling that tends to make us think we know more about what's actually going on than in fact we do? So let's look at some of the issues, some of the ways in which we can turn that rhetoric into a reality. And what we have to realize, of course, is that sequencing the genome is not the same thing as understanding it. Just because we can sequence the genome for $1,000 doesn't mean we can understand it for $1,000. And as we speak, the development of bioinformatics, the interpretational algorithms and everything else that will be necessary to give meaning to that genome is the rate determining step in the advance of our knowledge. We have unprecedented data generation. You know, every day, you know, unimaginable quantities of data about individuals, about their genomes, about their health status are being generated. But how to store it, how to interpret it, how to use it practically is a technical challenge but it's also a human challenge because our framework, our conceptual basis is shifting so quickly that we need to be constantly thinking about the way in which we structure our ideas of health and disease. Now, precision diagnosis, the sort of thing that comes from whole genome sequencing, is excellent because it means you can focus right down on the presenting problem. But, of course, if you sequence a person's genome, you find out an awful lot of other things which maybe you and they were not expecting. So how do you handle those incidental findings? How do you handle the unanticipated knowledge that you generate? And how do you engage with the patient, with the family, to establish what they want to know? What sort of information that you might have would they like you to share with them? And how certain do you have to be about the link between the genome analysis and the phenotypic change that might result in the emergence of a disease? And how can we handle this in healthcare systems around the globe that are already under pressure from rising demand, resulting from increasing population size, from aging, from the ability to intervene in a growing number of areas? So there is a kind of real significant management issue to bring this new knowledge into practice. Now, what about patients? The new knowledge, the new treatments give us hope. Of course they do, but most diseases remain at best intractable, whilst the majority are still untreatable. And the novel therapies coming out from the R&D process tend to be expensive. Expensive because the regulatory system requires that we prove that they're safe, that they work, that they do the business. But the traditional methods, the randomized double-blind placebo-controlled trials, the large-scale studies, are not possible when diseases increasingly are fragmenting into smaller and smaller genotypically distinct subsets. So there is a fear of increased inequity, the exacerbation of inequality between the rich and the poor. And that's not just between nations, it's within nations. There's the fragmentation of disease. What about those people who ostensibly have got the same disease, be it breast cancer or bowel cancer or coronary artery disease or something, but some of those people will be targeted by an effective therapy, but there will be others for whom the research has yet to reach. And maybe those people won't be able to benefit from interventions in the foreseeable future, or maybe even ever, because the industry will not see a method for generating a return on the money necessary to invest through dealing with smaller and smaller subsets. And if that happens, if the confidence in solidarity-based healthcare systems breaks down, then there'll be a loss of public support. We won't be willing to see taxpayers' money, our social insurance schemes or whatever, continue in order for those of us who are not wealthy to provide access to healthcare for the wealthy in the form of a subsidy for those who might be better able to afford it themselves. So what about a healthcare system for the 21st century? We need to think about infrastructure. We're still building hospitals based on a 19th century organ-centered concept of disease. So, we have cardiology departments and gastroenterology departments and neurology departments. Maybe we need to build hospitals that are based on biological pathways that are shared between organisms. We need to think about the personnel we require, the skill mix that we need within our healthcare systems. Pathology is changing dramatically. We're going to need a lot more bioinformaticians, maybe a lot more counsellors than people who can do the wet biology, which is increasingly machine-driven. And we're going to need to develop programs of initial education and in-service training, so those of us who, so that professionals can keep up to date with the pace of change. It's said, and It's a gross exaggeration, I know, but you can tell when a doctor qualified by the drugs they prescribe every day. Research has shown that clinicians are able to accommodate, somewhere between 2 and 10 changes to their clinical practice every year, and more than that, and they just can't keep up. So we need to think about new ways in which we're going to train the people to do the business. We need to educate the policymakers and planning so they can think in ways which will allow this to be incorporated into the investment, the decisions they make about structure and organisation. And most of all, we need public engagement and communication so that the citizens, the patients, the families who stand to benefit understand what the gain is and how best to address the challenges that are being created by this incredible outflow of new knowledge. And don't get me wrong, I'm not knocking that new knowledge. It is wonderful to be having to face these challenges, because without this new opportunity, diseases that might become treatable would remain untreatable, and avoidable harms would still be allowed to happen. So to build the future, we need sustained effort and investment. We need high-quality biomedical research. We need that research to be fitted to patients. Make the things you want to know reflect our lives. Don't try and make us fit our lives to enable you to find out the things you'd like to know. And that research must be translated into improvements in services and support. And that means we need registers, disease registers. We need biobanks, tissue and sample collections that are at scale in order for us to do the investigations. You're telling me to shut up, aren't you?
You can have another minute.
Thank you. I shall speak even more quickly. We need an appropriate ethical framework so that I consent to you doing things that you would like to know, and we need proportionate and appropriate regulatory mechanisms. I've mentioned that the old system is not good. We need sustainable pricing because at the moment the cost of drugs is escalating, the number of drugs is increasing, and the healthcare systems are struggling to keep up. And to do that, we need engagement with the industry who makes these new treatments, but also input from patients and families as partners in this process, not as subjects about whom interesting things are attempted to be sought out. So tomorrow's professionals, that's you. That's you I'm talking to. You will be facing an integrated world where the science, the politics, the medicine, and the broader societal issues all come together to create the opportunities for you to liberate the intelligence and the creativeness that you have, to fulfill the motivation that you express in order to improve the health care available to patients and families. We will depend on your scientific and clinical excellence, but you will also require an ability to situate this new knowledge in a broader context, to explain what you're doing to people who maybe have difficulties in keeping up with the ideas that are being generated, and to communicate the value of the insights that you're generating to a public which is not, by and large, scientifically very literate. So you can carry the public, the politicians, the media with you, not just in a local or a national context, but in a global context. Because this is bigger than Alexandria, it's bigger than Egypt, it's bigger than the Middle East. It's global in terms of its impact. So we need to rebalance the curriculum to make sure that in addition to your scientific and clinical excellence, you're able to engage with the society so that they will continue, that we will continue to support you in the endeavour on which you have embarked. So in order to realise the potential, we need the evolutionary perspective. We need to recognise that things take time. We need to reconcile the different time horizons that patients, that academics, that industry and politicians work for, and we need to develop tools that are fit for purpose. In other words, that will encourage that translation that's so important. And we need to recalibrate the debate and square off the graph of quality of life versus the quantity of life. We're good at allowing people not to die for longer. We're not yet good enabling them to enjoy those extra years in a way that are full of meaning and quality. So finally, why should we do this? And the answer is because we're worth it. All of us, each and every one of us is worth it. Good health is just an incomplete diagnosis. We all will need to benefit from high quality medical care at some point in the future. So we need to create a society where that is available and provided in a way that we can afford it. Now, the advances in genomics are creating those opportunities. But my message to you is, in order to realize those opportunities, you have to seize the day. Carpe diem. Thank you for listening.
Thank you, Alistair. This is one of the very few occasions in which I have the opportunity of listening to somebody as an advocate of the patient. I mean, it's very rare, at least in my experience. So we appreciate very much your insights.
Thank you.
Now we have a professor of cardiology, Dr. Abdallah Ilaga. He is a professor of cardiology at the Cairo University. He has been associated with the National Institute of Health in the United States for about 9 years. And we're very honored to have you at this presentation.
Good evening. It's a pleasure actually to be here today in this magnificent place, magnificent city. What I'm gonna discuss with you today is it's an innovation in medicine. But my goal actually is not just to describe what we have done in the United States. My goal is to show and to clarify the idea for you, and maybe in the future one of you come with a new idea and say, okay, why don't we apply this in a different field of medicine? And that's what is my goal. So the title is Endothelial to Mesenchymal Cell Transition. I know that many of you are not physicians, so I promise I will touch with the base. I'll just talk basically. So, you know, human cells consist mainly of two cell types, epithelial cells and mesenchymal cells. What are epithelial cells? Epithelial cells are simply the cells that are lining our bodies, like the skin. It consists of epithelial cells. Your hair. Unfortunately, I don't have enough hair. So your gut, your stomach, has an epithelial lining, okay? But what beneath the skin? There's muscles. Muscles are mesenchymal cells. The heart is mesenchymal cells. Fibroblasts are mesenchymal cells. So that are the two different types of cells in our body, epithelial and mesenchymal cells. And as you see here, these are epithelial cells. The epithelial cells are attached to a basement membrane. You see this blue line? This is called basement membrane. So they have a skeleton. They are anchored into these basement membranes by what is called junctions, tight junctions, gap junctions, different junctions. By contrast, we have the mesenchymal cells, the green one here. As you see, these mesenchymal cells, they are not attached to the basement membrane. They have different function, different shape, different morphology, and what else? They can move. They are not attached to the basement membrane, so they can migrate everywhere in the body. So this is an example of epithelial cells on the left, mesenchymal cells, and look here what is in the middle. These are metastatic cells, the cancer cells. They look like the mesenchymal cells. And actually what we found, we learned it from National Cancer Institute at NIH, NCI, and what they found actually, they had actually in 2010, President Obama came to NIH and then they declared a victory over cancer. And that was true because now the mortality rate for the first time in history of cancer, just stabilized. That was like a curve going up. But in 2010, it's stabilized. So, and it's going into downward curve. Why that? Because they discovered a lot of mechanisms. The EMT, or the endothelial mesenchymal transition, was one of them. Look what they found. They found actually that the cancer by itself, it doesn't kill the patient. It just killed 10% of patients who get cancer. What killed the patient is metastasis, is the spread of cancer cells. But you know, the cancer cells itself are attached to the basement membrane, the blue line that I just showed you. They are anchored to the basement membrane. They cannot migrate. In order to migrate, they have to undergo what is called epithelial mesenchymal transition. They have to be different morphology, different function. When they change into mesenchymal cells by certain pathways, they get access into the circulation, into the blood. And when they get access into the blood, they can spread everywhere. Go to the brain, go to the liver, anywhere. And when they go to their target, they have a reversible mechanism, mesenchymal epithelial, where they are just transferred or changed into cancer cells. So they thought about it. If we stop this mechanism, we're going to stop the metastasis. We got this idea because where I work at the NIH, the NHLBI, the heart thing, is just close to the Cancer Institute. So we learned from each other. So let's have a definition here for the epithelial mesenchymal transitions. It's an orchestrated series of events in which cell-to-cell and cell extracellular matrix interactions are altered to release these endothelial cells from the surrounding tissues. And the cytoskeleton is reorganized to allow the movement of these endothelial cells, and they allow its migrations. This new mechanism is called epithelial mesenchymal transitions. But in the heart and the vessels, we have not epithelial cells, we have a different name. We call it endothelial cells, because it's a subclass of epithelial cells. And this mechanism, as I told you, is reversible. So we can have epithelial cells transformed into mesenchymal cells, and we have vice versa. So what happened? These resident endothelial cells delaminate from organized cell layer and acquire mesenchymal phenotype characteristics. They lose the cell-cell junctions. They lose the endothelial markers. So each cell in our body has a marker. If it's endothelial, it has endothelial markers. If it's mesenchymal, it has mesenchymal markers. It's like Ahli and Zamalek. So if you have red or white, so it has a marker on that cells. So you can recognize these cells, is it endothelial or mesenchymal in origin. So what will stimulate this process to occur? Of course, injury. Injury like inflammation, like hypoxia, like patient had a heart attack, patient has an injury in his blood vessels. And that will promote certain pathways. One of them is called TGF-beta pathway, and that will change. Cytoskeletal changes will happen, and these endothelial cells will acquire the new mesenchymal markers. This is an example of one of the proposed mechanisms. It's called TGF-beta pathway. It's a huge pathway. I'm not going to go into details of that. But I'm just going to tell you about this epithelial mesenchymal transition has 3 types. One of them actually is type 1, occurs in the embryo. So during embryogenesis, many of tissues undergo this process. So they can change, they can sharpen some organs, enlarge some organs, change some organs. Type 2 occur in the regeneration, and that's what we are talking about today. And the third type is the cancer that is involved with metastasis. This is a psychological test. So they said, the psychiatrist said, if you giving a lecture and you show this slide and you see the young lady, That would let you that most of the audience are concentrating and are following you. So how many of the audience are seeing the young lady here? Oh, wow. Excellent, excellent. So if you're seeing the other lady, the old ugly lady, that means you are not following me and I'll be dissatisfied. Okay. So you see this young lady doing like this, has her profile, and there's an old lady with this is her nose, and this is her mouth, and putting a white scarf on her. Okay, so that you are following me. Okay, I'm happy. So let's talk about science. So what will happen with this vein graft? So we applied this mechanism in the vein grafts. So why vein grafts is important? You know, if somebody has a heart attack and went to a surgery, which is called, they do a bypass. They harvest the veins from his leg and they put it as a conduit, as a bypass. But unfortunately, it's not always successful. This is an example of a cath. I'm a cardiologist, I do cath. You see, this is the blood in the vessels. This is a vein graft. And you see there's interruptions here in this stenosis. It's closing after a while. Why? Because there's inflammation, there's thrombosis, there's a proliferation of the vascular cells. About 40% of vein grafts will fail within 12 to 18 months after implantation. And this high failure rate is attributable to a number of pathological processes. And mainly is the adverse vascular remodeling that leads to vein graft failure. So what's the classical theory? The classical theory, they said, the lining of these veins or arteries or any vessels, they have an endothelial cell damage. And do you know what's endothelial cells are important for us? If you have a healthy endothelial cells, that means you are a healthy person. If you don't have healthy endothelial cells, that means your situation are in danger. Actually, endothelial cells that secretes all the important substances, important hormones. So when you do exercise, the endothelial cells will secrete substances, make your vessels dilated, wide, so more blood is going to nourish the organs. If you don't have healthy endothelial cells, that means you are diseased. And that is the basis of a lot of cardiovascular disease and other diseases. So endothelial cell damage, then there's a growth factor release, which leads to vascular smooth muscle proliferation, and these will encroach on the lumen and migrate to the new intima, and finally it will close. So our hypothesis was, why not the endothelial mesenchymal transition will be involved in this process? Instead of the muscles coming from the media and migrate, no, it's the endothelial cells that is lining the blood vessels that will undergo transitions into a muscle cells, a vascular smooth muscle cells, and will close that. And if this is true, if this hypothesis is true, so we can treat a lot of diseases related to this mechanism. So what we use transgenic mice. So we have to use genetics. Well, this is a mice. We put it in green because we manipulate its genes. How do we manipulate? By genetic engineering, we get that every endothelial cells will give green fluorescent. So even if these endothelial cells change into any other cells, like mesenchymal cells, they will still give this green fluorescence. This is what's called lineage tracing. So we took the jugular vein from these mice, transgenic mice. We put it in a femoral artery. So we are putting an arterial pressure into a vein. And this is the image. This is the vein graft. So, and here's the interesting part. What you see here, this is the endothelial cells lining the vein before any injury. This is at day 0. And what is in red, this is the marker of endothelial cells. And when we put both together, that will say these endothelial cells because they give green fluorescent and they give the red color of endothelial markers. So we know that these are endothelial cells. After waiting 35 days, look what happened to the vein graft. It degenerates, it closes. You barely see the lumen. Okay, so please concentrate in this slide. So we have markers, endothelial markers, CD31, VE cadherin, endogenous. These are all endothelial markers. We have smooth muscle cell markers, which are mesenchymal markers, like these you see here. So if you see this smooth muscle cell markers, that means they are encroaching on the lumen. But look, when you put these together and merge both of these, you find that these endothelial cells giving green fluorescent, now they are not endothelial cells. They are mesenchymal cells. They are muscle cells. But their origin, we know because we put a mark on them, green fluorescent. They are coming from the endothelium. This is a transitional zone when the cell are losing its endothelial markers and are gaining its mesenchymal markers. This is like something that you see for just few hours in between the mesenchymal and endothelial stages. We want to make sure that these cells are not coming from the bone marrow. So we are putting the markers, we are testing the markers of polymorphs, neutrophils, lymphocytes, like these markers, F4, AT, CD30, are looking for inflammatory cells. We are making sure. And nothing of these markers are positive here. So we now confirming these are not coming from the bone marrow as the classic theory. Oh, maybe the bone marrow is sharing in this and they're sending these new cells into the blood vessels. To recapitulate that endothelial lineage cells contribute to the formation of the new intima, and these endothelial cells will lose the endothelial markers, gain smooth muscle cell, the mesenchymal markers, and proliferate into the intima. And these smooth muscle phenotypes will be less mature than the endothelial cells. What is the pathway? We found the TGF-beta pathway is active. What are the markers of the TGF-beta? They are one of these are called phosphosmad. We found these are positive, and they are also a marker with the green fluorescence that will tell us that these are originally coming from endothelial cells. There are different transcription pathways or transcription signals that are involved in this pathway, like snail and slug. We need to know more about it because when we stop it, that will give us a good result. So, and here's the surprise. When we stop this pathway, the TGF-beta pathway, look what happened. This is the control, the one here, this is the control. Look at the lumen. It's almost obliterated, it's closed. But when we give antibodies to this pathway, look what happened. Just below it, the veins still keep patent. So when we stop this process, we can have the vein still open. What about a different genetic pathway? We can use what is called knockdown. We know that the SMAD is responsible for that. We do a knockdown and look at the results. Here's the result. We can have, this is the control before doing the knockdown, and this is after the knockdown. We have the vein is still patent. So to summarize, EMT is contributing to the smooth muscle proliferation in the new intima, and the TGF-beta pathway is involved in this process. And when we antagonize the TGF-beta signaling by TGF-beta antibodies or knockdown or SMAD2 deletions, that will result in favorable vascular remodeling. I'll just give you just a few slides about what we are doing now. We are applying this in the heart. You know that this is a picture of a patient who died with heart attack, myocardial infarction. And you see these white areas, these are fibrous area. These are dead, these are scar. But the questions, where are these fibroblasts coming from? These are mesenchymal cells, fibroblasts like smooth muscle cells. So are they coming from the bone marrow, or they are coming from the blood, or are they just resident fibroblasts in the heart and they are just recruited? We don't know. So what we are doing this now, we are just applying this to this theory. Maybe the fibroblasts are coming from the endothelium of the heart. Why to think that it's just there are fibroblasts? No, these may be coming from the endothelium of the heart, which we have numerous, we have billions of endothelial cells in the heart. And that's our hypothesis, and maybe we can discuss it next year when we have the result ready. So if anybody interested in something else, we can think about the cardiac myocyte regeneration. It may be responsible. Angiogenesis, lung fibrosis, pulmonary hypertension. So this mechanism has a lot of potentials. We need to replicate it in the large animals, and then for humans, we need to explore it for myocyte regeneration, to use it in atherosclerosis. Atherosclerosis is the main problem nowadays, and the #1 mortality in the United States is, also I think in Egypt, is atherosclerosis. And maybe for in-stent restenosis, and for development of a new stents that elude these anti-TGF-beta pathways. If you're interested, we just published this in Science 2 weeks ago, in March 15th, in Science Journal, in Translational Medicine section. Thank you very much for your attention.
Wow. This is part of this new knowledge that is coming on that Alistair was talking about before. And it's also a very good example of state-of-the-art cell and molecular biology applied, not yet to medicine, I would say. It hasn't reached the healthcare yet. But as my advisor used to say, it's very, very promising. And also, at the end, it's like magic. I mean, you have one of the major molecules that are responsible for this, like TGF, and then you block it with an antibody, or you block it with an old mutant, and then you see these kind of results. Well, let's move on. And our next speaker is Ahmed Ali. Founding director of the Center for Aging. Now we have another interesting subject. And associated diseases, Helmi Institute of Medical Sciences, the White City of Science and Technology here in Egypt. The founding director of the Center for Aging and Associated Diseases. It's another person that has returned to Egypt. I suppose that is a trend. A few years ago, I was commissioned by United Nations to establish an institute in India, in Calcutta, of biotechnology. And what was my surprise, there were 30 scientists. Out of those 30 scientists, I have known 15 of them in the United States. So there was a big trend to come back to India, and I'm very glad to see that probably is occurring the same thing here. Dr. Ali, curriculum is very extensive. I would just, for time's sake, I will invite him to talk. Thank you.
Thank you so much for the nice introduction. I should start by saying Assalamu alaikum. I think I should first commend you all for being here until this time, and probably willing also to concentrate without the picture for the old and young lady, because I use this picture actually for a different purpose, because it's the interface between health and between aging, and we are interested in aging, but actually the talk today is about an underlying factor in aging, what we are doing here in Zuweil City is how to, actually the question is how to tackle the maximum number of diseases and conditions that are interesting to Egyptian population. And this is how we came up with the idea and the design of this center that I'm going to talk with you about. But the first slide that I use is actually a little bit of a depressive slide, because it actually is reporting on the most prevalent diseases in Egypt. And as you can see, we are accomplishing very, very advanced places in most of these diseases. As you can see, we are either number 1 in bladder cancer, we are number 3 in hepatitis C, and number 1 in hepatitis C, and number 3 in hepatitis B. We are 3 also in endocrine disorders, which is an extremely important sort of diseases that are affecting all of our lives. And the question was now, how are we going to handle all of these kind of very advanced ranging or very advanced ranking of us being on the top of the list? The first thing that we thought about is to establish a Helmi Institute of Medical Sciences in Zuweil City of Science and Technology, and this is essentially hosted, the first center to be hosted in the institute is the Center for Aging and Associated Disease. And to give you a perspective, I think I should go faster. To give you a perspective that's probably is very, very simplistic, very reductionistic. We are interested in actually 2 of the most important reactions to life. These 2 most important reactions, chemical reactions to life, is the first one, which is the reduction of oxygen to produce water, and this is an enzymatic reduction, and it produces a lot of energy, and this is the energy that all human life, all life on this planet relies on, okay? The other reaction that we are also interested in is involving oxygen, and this reaction is the electron transfer to oxygen to produce superoxide radical. This is one of the most important elements in aging and in diseases. In addition, it is also very important to signaling, and it is important in, I think, also in the epithelial mesenchymal transformation, I believe. And the life actually have managed to try to maintain oxygen concentration within an optimized range between 1 and 10 micromolar on the subcellular level. And this is essentially to maximize the enzymatic transformation of oxygen into water and to harness a lot of energy while minimizing the chemical transformation of oxygen to superoxide radical, which is responsible for a lot of diseases. However, of course, we know now that life also managed to go around this kind of chemical transformation by using enzymes that are specialized in producing superoxide radical, but this is a different subject. I'm not going to talk about it today. These 2 reactions take place in mitochondria. And mitochondria are fascinating organelles in the cell. And in fact, I kind of have this kind of grand unified theory of biology in which mitochondria really play very important roles in health and diseases. I can give you a list. I actually tried to put a list of the diseases that are involving mitochondria, and actually the list goes forever. So I would actually just screen through it, and you can see in brain, in cardiovascular diseases, in peripheral and autonomous nervous system, in muscles, in the eyes, in hearing. A lot of diseases and conditions are very well established to have critical roles of mitochondria and mitochondrial dysfunction. And that's why I focused on establishing a state-of-the-art metabolic screening facility in Zuweil City, and I'm going to talk to you about it. But after just confirming that most of these diseases, including cancer, obesity, cardiovascular disease, and aging, are involving mitochondria and mitochondrial dysfunctions. One of the very prevalent and very known theories of aging, for example, is the mitochondria theory of aging. The two mice that you're looking at now, they are actually the same age. But the one with gray hair and with hunchback and with this kind of cataract on their eyes, which is showing an aging phenotype, is essentially having a mutation in the gene that's encoding for one of the complexes on mitochondria. Complex 1, subunit on the complex 1 mitochondria. And this leads to an accelerated aging phenotype, indicating that mitochondria is extremely important in the aging phenomenon. The aging phenomena involve a cumulative sort of damaging to mitochondria that leads to an increased level of production of reactive oxygen species, including or starting from the superoxide radical, which I explained to you about. And in the same time, this causes more random mutations to the DNA and to the components of mitochondria that leads eventually to more error in encoding complexes and shortage in energy supply. Of course, this is very relevant to so many diseases. I think we have a framework, a theoretical framework in our center that's handling the whole story of starting from the story, a life story of an organism. And in this kind of simplified scheme, you can see that the purpose of any organism is to survive through the reproduction period. And going through this, there is a concept that's called antagonistic paleotropy, which means that what any organism is caring for is to pass its genes, no matter if these genes or some of them would confer some sort of damage or problems later in life. And this, of course, includes genes that are responsible for cancer and cancer transformations in the cells. Then after that, we have the theory of high rate of metabolism, or the theory of rate of living, which affects the rate of metabolism. And believe it or not, the rate of metabolism is one of the most valid connections between a lifespan and of an organism. This, of course, is based on the production of reactive oxygen species and more damage to cellular components that causes some sort of accumulation of damages, senescence, diseases, and eventually aging and death. We are interested in reactive oxygen species as a node in which you can essentially control and intervene with this kind of vicious circle. And in order to do this, we are establishing facility to be able, that enables us to study to study the cell and to study the biology on many multiple levels, starting from atoms and molecules. So we have sophisticated machines to detect and to study the dynamics of reactive oxygen species. This is called electron paramagnetic resonance spectrometer. We have a device that would allow you to study in details the oxygen consumption by cells and by mitochondria and by many other things, and I will explain more about this. We have another system, another device that would allow you to study metabolic pathways, because metabolic pathways are multiple. You have metabolic pathways that rely on mitochondria. Others rely on glycolysis, and I would say in this in the EMT transformation, the transformation would definitely involve some sort of metabolic switching, because when you move from epithelial to mesenchymal cells, you essentially would have some sort of micro-hypoxic environment to the aggregates of the cells. This would force the cells to switch their metabolic profile. And it's certainly something to try, and maybe me and Dr. Abdullah would probably talk about this. Then if you move forward, we also have some sort of imaging, and we can monitor tissues, and then also we are planning to establish a behavioral study and electrophysiology units to allow us to complete the cycle of studying, starting from cells up to a whole organism. So how to study mitochondria? Mitochondria is a tricky sort of organelle, and usually people that are working on mitochondria they consider themselves very elite, that they actually created a whole expression for them, which is called mitochondriacs. And although I'm not considering myself a mitochondriacs, but it is essentially a very, very tricky thing to study. We study oxygen consumption, we study reactive oxygen species production, we study ATP, and we also study the different types of reactive oxygen species that are generated, and we know also where and when they are generated, the effects on different tissue components, including the effect on the membranes, including the effects also on the DNA mutations, and levels of carbonylation of proteins that affects the function as well. We also study the signaling pathways that are triggered by mitochondria, including apoptotic pathways, calcium, and also thermogenesis, because mitochondria is responsible also for generation of heat. The structure, morphology of mitochondria is an important element. We are establishing now electron microscopy units, and also the dynamics, which involves the mitochondria fission and fusion in relation to different situations. Here is a little bit more details about the components that we are using. This is an Ouroboros system. When we purchased this system, we were the first to buy it in Africa and in the Middle East, the whole Middle East. And they actually celebrated this, that they sold the first unit in Africa and in the Middle East. This is a sophisticated system that would allow us to study down to picomole amount of oxygen concentration, which would enable you to study a very small number of cells, how they consume oxygen and under what conditions. Not only that, but also you can add accessories that would allow you to study hydrogen peroxide production in the same sample. You can study also ATP production. You can study calcium. You can monitor also many other components that are very important to the dynamics of mitochondria. The very big advantage about this system is that it would allow you to study even tissues without having to isolate mitochondria. Isolation of mitochondria is a very lengthy procedure, and it's very harsh because it involves mechanical spinning, and this would always impose a certain level of damage for the mitochondria. But this system would allow you to study mitochondria in homogenized tissue, and we are successful in doing this in many, many types of tissues. For example, this is a muscle tissue, and of course, I think this would indicate how easy to do this. What you do is actually you try to prepare the fiber bundles, and then you place them in the system, and you challenge the system with different substrates while monitoring oxygen consumption and other parameters through fluorescence modules. And then what you see, or the outcome, is the respiratory efficacy and the rate of oxygen consumption through this kind of trace, in addition to other components. And I'm going to give you just quick examples of what we get here. For example, this is a comparison between a healthy heart from mouse and a diabetic heart. And it is until now, it is not really clear how the heart or how the mitochondria in the heart respond to diabetes. There are a lot of theories that it actually responds by producing less free radicals or more free radicals. It's actually not known. And this system is allowing us to study this in real time. So if you compare these two experiments have been done or was done in parallel. And you can see that the rate of oxygen consumption in the diabetic heart, which is expressed in the red trace here, is actually less than the normal heart, indicating that the mitochondria in the diabetic heart is less efficient in utilizing nutrients and producing ATP. If you compare also what's so-called the maximum respiratory capacity, by maximum respiratory capacity we mean how efficient the mitochondria can go. What is the maximum limit of the work that your mitochondria can do? This is important, for example, if you want to challenge your mitochondria by suddenly imposing certain exercise or something like this. And the higher the trace, the red trace, it means that your mitochondria is healthier. And in fact, this has been used to evaluate the performance of sports players. You can actually say whether Abu Trika can play today or not. Of course, he's not going to play anymore, but you can also, and in fact, this is reported. People are using this to predict the winning horse by studying the efficacy of mitochondria, studying the highest level or the maximum respiratory capacity, and with a confidence level that's exceeding 95%. So it's amazing to use this system. Okay, the other system I'm going to skip now because this system also would allow us to have some fluorescence systems or accessories to allow you to monitor reactive oxygen species produced at the same time. I don't think I will have the time to go through all of these details, but if you have a cellular system now, I'd like you know, sometimes it's very important, especially in studies similar to the EMT transformations or the cancer transformations, you would like to know essentially how cells are behaving while you challenge them with something, okay? It's highly complex organization in the cell. And you can see this is only monitoring the small molecules that are going in and out during a burst of metabolism. We have a system, this system is essentially designed to monitor all metabolic pathways, including fatty acid oxidation, including amino acids metabolism, including also the oxidative phosphorylation by mitochondria. And this system is ingenious in terms of the idea where mechanically you compress the volume of the sample so that it is about 6 microliter, and in this case you enhance the sensitivity tremendously. This is based on monitoring oxygen consumption and also on lactic acid release. How long time do I have? 1 minute? Okay. Well, we are able to use this to monitor different metabolic pathways, and we can phenotype, for example, cells and see the metabolism, how the metabolism is doing, whether it has more glycolytic activity like the case in cancer cells. And also, we have been able to use this sort of monitoring to try to intervene with liver cancer. And how to do this? In fact, when we know that the metabolic transformation happens in cancer cells because the microenvironment is hypoxic. And cancer cells starts to rely more on glycolytic pathways, while the oxidative phosphorylation or the mitochondrial pathways are actually diminished. So somehow, if we can switch this kind of phenotype, if we can bring them back into the normal mode of metabolism, we probably will be able to eradicate cancer cells without affecting normal cells. So our goal now is to try to find metabolic switchers that would allow us to reprogram metabolism in cancer cells, and we have some indications that we are putting our hands on the right path while actually founding some compounds that allowed us to enhance oxidative phosphorylation while inhibiting glycolysis, and this led to massive killing of liver cancer cells. I'm not going to go into details, but actually 2 hours were enough to kill almost or more than 90% of HepG2 cancer cells in vitro. We're working harder to try to find ways to improve our interventional strategy. But as you can see, mitochondria, and I'm closing with this nice painting by Eqimt, and I just noticed that Eqimt is trying to express the fight between life and death, as you can see. But both of them, they look like mitochondria, and you can see that mitochondria is even involved, probably unconsciously, with what Eqimt has drawn. And with this, I'd like to thank my group, and in fact, my task force is sitting in the 4th line here. These are my students. They are doing a wonderful job, and I'm very proud of all of them. And hopefully next year, you will see some sort of more advanced results. Thank you so much for your listening.
I told you at the very beginning, we have a very distinguished panel and talented, and me coming from Venezuela, I feel proud of looking so much talent over here. And this has been an example, I would say, of translational medicine, translating physical chemistry into clinical applications. So we're going to have our next speaker, Eva Kasem. She's a PhD from Manchester, UK, and Director of Clinical Genomics Center. So we had gone through a patient advocate, cell and molecular biology, physical chemistry, and translational medicine, and we want to wind up with clinical genomics. So please.
Thank you very much. It's a pleasure and an honor to be here in the BioVision. So I would like to thank the BA for inviting me, and I would like to thank you for saying that I'm a PhD student. I wish I was. It's been a while now. My talk today is entitled Genetic Study of HCM in Egypt, and I will be presenting today the early results from the BA HCM program that is led by Sir Magdi Yaqub, and it's my pleasure and honor to represent the BA consortium, the BA HCM consortium to give this talk on their behalf. Now, why is it important to study the genetics of hypertrophic cardiomyopathy? Now, I can see amongst the audience many of med students. I would start with just very briefly, what is hypertrophic cardiomyopathy? HCM is diagnosed when you exclude other causes of hypertrophy of the heart that results from the systemic hypertension or aortic stenosis. So sometimes we used to call it the idiopathic hypertrophic cardiomyopathy. Now, the prevalence worldwide seems to be the same. The symptomatic cases have an incidence of about 1 in 5,000. The prevalence reported in several worldwide population is 1 in 500. Now we are wondering what is the proportion of the genetically positive, yet they haven't shown the symptoms yet in HCM, and I can assure you that this is much higher than the 1 in 500 prevalence. And in our experience, we have actually diagnosed 1 in 100 amongst the healthy controls of the Egyptian population who have no history of any cardiac condition, and yet we found a positive mutation in sarcomeric genes. Now, what is the approach we are applying in the BA HCM program? It's actually an interdisciplinary, so it's an integrated program in the diagnosis and in the research work and also in management of HCM. So when the patient steps into this program, they must be subjected to a pre-testing genetic counseling on the disease and on the genetic testing, the possible results, and how they would interpret, how do we and them interpret these results. And of course, Dr. Kent has touched on this, that you should know the patient should know what to expect and how to interpret. This is going hand in hand with the clinical management and the clinical diagnosis. We do the genetic testing, and when it is positive, we call back the patients and tell them about the results and ask them if they would extend this to the family so that they can have family screening. So the familial members are also part of this program. Now, the most common genes that are involved in hypertrophic cardiomyopathy are the sarcomeric genes, but they are not only the only gene members. However, as a first-line screen, it's always advisable to start with what is common. Cost effectively, that would be a good policy to start with. Now, the beta-myosin heavy chain, which forms the thick filament of the sarcomere, and is a common member that is involved in HCM. The myosin binding protein C, which is a structural protein and also a regulatory protein, have a big role in HCM. And one of the troponins, the troponin T, is which is a regulatory component in the thin filament interacting with the actin, is also a good candidate. So it was good to start with these three sarcomeric genes in our study. Now, so far, the HCM patients recruited in these programs are nationwide from Alexandria HCM Clinic in Alexandria Faculty of Medicine Cardiology Department, have now recruited 152 index HCM patients from the Minofeya in the middle between Alexandria and Cairo. There are 153 patients registered in their clinic, and from Cairo, the capital, it always beats other governorates. So we have 200 patients registered there, and from Upper Egypt in Aswan Heart Center, we have 12 patients. Now, I will concentrate from now onwards in my talk on the results which we have obtained from the first 192 patients who were recruited from 2007 to 2010. And the results have been published recently. Now, how did we go ahead with this study? First, we had to screen 200 presumably healthy control from the Egyptian population to have an idea on the background of the genetics of these sarcomatic genes that we are going to be interested in screening in the HTM index patients. And as a second step would be a cascade screening of the family members in which, whose index, the family in which an index we found a mutation. So what technology did we use? Well, we used as a first-line screening methodology using denaturing high-performance liquid chromatography. So we are mainly here looking very easy, quick methodology, though very tricky, and you can always ask Rimon how tricky it is to work with this machine. But anyway, we will be looking at the different parts of the genes. We split the genes into parts called exons, and to amplify them, we'll call them amplicons. And for each amplicon, we're going to have a look at a number of patients to look for the profile of this amplicon. When they are all the same here, we're happy that this represents the wild profile. And when we have a difference, this means that this patient who's different from the profile does have a change in this part of the gene, the amplicon. So we will have to look further what caused this change, and the way to do that is by Sanger DNA sequencing, and our scientists are now experts on these two techniques. Okay, so the results of these patients, as I mentioned, have been published in the Journal of Cardiovascular Translational Research, which came out early in 2013. Now, overall, from these cohort, we did find a mutation, a pathologic mutation, in 40% of the patients. And 60% we did not find a pathogenic mutation in these three genes as a first look. Now, our cohort of HCM patients did represent 40% of our patients had a family history of a HCM or sudden cardiac death in their family. So when you just concentrate on those patients who are called familial, you would find that the proportion to find a mutation is much higher. It's over 60%. So when you are really selecting your patients, the possibility of finding a mutation is much higher. So from our results, we did find that myosin binding protein C represented 24% of the positive patients. If we're just concentrating on the 40% who are positive, the commonest was myosin binding protein C, followed by myosin heavy chain, and then the least common was the cardiac troponin T. So our percentages, as compared with the percentages published from the European and the US cohorts, were slightly different. We had about a quarter of our patients were positive for myosin binding protein C. Half of this, 1/8, I would say, for the heavy chain, myosin heavy chain, and only 4% of the cardiac troponin T. This compares much less than what is reported in the other population. Now, we can have one of two assumptions. Either another gene is playing a role in our population more than these three common sarcomatic genes, or the cohorts are different and they were mainly concentrating on their familial HCM patients, in which case we would find we are much more likely to find higher incidence of mutations. So, just to summarize our results, the commonest type of mutation that was found type-wise is the missense mutation. A single amino acid is transformed to another amino acid, with a predictive, of course, effect on the function of this protein. And you have to go through algorithmic workup through bioinformatics in order to predict the possible functional effect of this mutation. And sometimes it's very tricky to assess the potential of pathogenicity, especially that 77% of the mutations, 65% of the mutations that we detected in our cohort were novel. So they were not reported in other HCM, international HCM cohorts. And the majority of the mutations detected were private. 3/4 of the mutations were private, meaning that they were reported once in one family. So it is very, very heterogeneous. Now, we did observe also that there are some patients who had mutations in more than one gene, and so we call those having double hits. And always with the double hits, you anticipate that the phenotype is going to be severe, and these patients need perhaps further attention, and the genetic characterization can have a role on the modification of the management, maybe in the risk stratification. Now, we did also find very interesting thing is that there were mutations that were recurrent in several patients coming from the same district. So, and we had, for example, from the northwest Egypt, where the Bedouins live, we had a mutation that kept on repeating from the Dumyat governorate. So this points to the possibility of the founder effect, and maybe this will be of value in screening for these mutations from these districts as a first look. Now, as I mentioned earlier, that when we get a mutation that is a missense mutation, resulting in a change of an amino acid to another, then we are in a bit of a confusion to determine whether this is really pathogenic or not, because there are several variants, polymorphisms in a different population where you can have changes in amino acids, yet they do not cause marked deterioration to the function of the proteins. So the co-segregation and the study of the mutation segregation in the family is very crucial in testing for the pathogenicity of these variants, rare variants. Now we have our patient here. This is our index patient. We did find 2 hits in the 2 different genes, and when we first looked at it, it's a missense mutation and one of the intronic sequence variant, which is not in the splice site. So it's likely not to be pathogenic. So we were concentrating on this as the pathogenic mutation. In fact, this did not prove the case, and in an affected brother of this index patient, we did find the intronic variant is the one that is co-segregating with the HCM phenotype, and therefore it was disproving that the missense is the most important pathogenic mutation in this family. Maybe this second hit would have an additive or a modifier effect on the phenotype. Now, we are benefiting from this genetic data in correlating with the phenotype of the patient and when to expect to find a mutation. Well, we did notice that, as I mentioned earlier, that if you have a history of HCM in the family or sudden cardiac death, there is a high likelihood that we would find a mutation in these sarcomeric genes, and this was statistically significant. The age, now the younger the age of the presentation, the more likely it is genetics, and then the more likely you would find a mutation. Again, this was significant, statistically significant. Now, when we compared with the actual clinical effect of the HCM, which is reflected as the main pathology of left ventricular outflow obstruction and thickness of the interventricular septum, which is the main paradigm in the disease, we did not find a significant correlation between finding a mutation and these clinical parameters. Now, again, as I mentioned, that the part of the study is to benefit the families who are participating in the study. And this is one of our families. And you can see that the Egyptians are very famous for extended families. So this is a family where there was several sudden cardiac deaths at young age of the SIBs of our index patient. So this was our index patient presented at 38 years of age. And we did genetic testing for this patient, and we found that in one of the exons of the myosin heavy chain, he did have a difference from the wild profile. We looked by sequencing, and indeed we did find a missense mutation. So we went back to the family. One of the SIBs, the youngest sister, had an interventricular septal thickness of 14 millimeter. Now the cutoff for diagnosis of HTM is 15, but the normal is 13. So you have a gray zone here for this sister. And so when we did genetic testing for her for this familial mutation, it was she was negative, and therefore she could live happily. Unfortunately, his son was positive for this mutation. His age was 12 years, and he's now put on a screening program with ECHO. Again, another example of familial HCM, and again, I would like to stress on the extended families of HCM and the presence of consanguinity. Now, the presence of consanguinity with HCM has two main implications. First, it will increase the risk of the autosomal recessive causes, the phenocopies of HCM. And second, you have to always make sure about the presence of consanguinity to screen for a familial mutation for the sake of, for example, of this little family here. She was negative for her brother mutation. This is the mutation in the family. She scored negative. His sister of this index scored negative. We had to screen for her cousin and husband in order to be sure that their kid will be okay. So do consider consanguinity in this side of the world. Future perspectives, well, now actually diagnosis is include taking on board the molecular analysis. It does allow pre-symptomatic diagnosis for first-degree relatives, and this is good for the follow-up of these families and maybe in the very near future for pre-symptomatic treatment. Expand the numbers of, we are currently expanding the numbers of genes that we look for in HCMs through the use of next generation sequencing, and this is through a collaboration with Imperial College. And this will allow us to do high throughput genetic screening. This is all dependent on strong collaboration that is wonderful in the BVA HCM consortium. This would allow effective genotype-phenotype correlation and investigate the fundamental mechanism in HCM. And now, after hearing the talk of Dr. Abdallah, of course there might be an important role on EMT and TGF-beta, because one of the pathogenesis of HCM is the fibrosis in this array of the happening in the myocardium. So definitely we will have some collaboration and crossing over. Now, the BVA HCM consortium is directed by Magdi Yacoub Foundation, and we are proud to have Professor Magdi Yacoub as our principal investigator and leader in this work. Bibliotheca Alexandrina is the auspice of and the nucleus of the molecular genetics lab that has undertaken this work. Of course, the national HCM clinics all over Egypt, referring cardiology consultants, the Aswan Heart Center, our patients. We are grateful to our patients for participating in this study and being patient with us, because of course the result does take a while. Our international collaborators in Florence in Italy, Carigi Hospital, Oxford University, and Imperial College. So as you see, together we can have a stronger heart. Now, I can't end my talk without showing this picture of the team of the molecular genetics lab. Professor Yacoub, of course, is our leader, and the beautiful young eminent scientists Rimon and Besra are here with us amongst the audience. So thank you very much for joining us.
Thank you.
Well, thank you. Another example of translational medicine. It occurs to me that, do you have a society of translational medicine in Egypt?
No, not yet.
Not yet.
But you need that.
Yeah,
I mean, I can see it forming here because you have so many aspects. I mean, physical chemistry, molecular biology, genomics, genetics, and there's got to be a tissue that puts all of that together that could have a tremendous impact on Egyptian society.
That's a great idea.
It's
That's
time-
what we need.
it's time to start with
You
this.
should do it as soon as possible. And then when you have the society, please invite me. So I will, I will enjoy that as much as I have enjoyed that today. But this society will not be complete if you don't have a patient advocate as well.
Absolutely.
I mean, that social aspect is extremely important. All right, so we have little time for about 2 or 3 questions. Yes. I encourage the students that are here to ask questions or comments. We all are family, so you could ask whatever you want. Yes, please.
Okay, I have a question for Dr. Hibba about the mutation in the intron, and whether you have any idea what might be taking place there at the molecular level. Do you think that it might be having an effect on splicing, or is there any?
Thank you very much for this question. Yes, indeed, most probably it will be causing splicing effect. We cannot be sure, though, what it is causing without studying the RNA. This would be our only proof to do the study and to look for the transcript or the protein and prove that it has got an effect. However, the co-segregation does give us assurance that this is segregating with the phenotype, whilst the missense mutation is not. So if you like, this is a biologic answer that it is probably having an effect. Without the RNA, there is no absolute answer.
Is it near an obvious splicing signal?
Absolutely. Now, the consensus splice site are dinucleotides. Donor site, the AG and the GT. These are the consensus dinucleotide. However, for 10 nucleotides around these consensus splice sites can cause a splice site effect.
Yes.
Thank you.
And please identify yourself.
Okay, I'm a postgraduate student in Zoya City. My name is Khulud Arafat, and I have 2 questions, one directed to Dr. Hibba. Following up on the last question, given it is an intron problem, what do you expect? Would it be related to epigenetical dysfunction that would cause such a phenotypic disease? And also, it would be related to Dr. Kent's speech, using such information that you get out of the genomic sequencing. What do you think of preventive therapy? And for the preventive therapy, you need to know the mechanism of the disease so that you can intervene. So what do you think of this? The other one that is directed to Dr. Abdullah. For the endothelial mesenchymal transformation, would it be that a paracrine mechanism between the cells are the thing that is causing this transformation? And is it specific that no tumorigenic growth would occur? What are the controlling parameters that induce such transition? And whether there are any side effects that are reported or long-term studies that to be implemented to make sure that such therapy is of good value. Thank you very much for your time.
You should be a speaker next time. Please, if we can be very concise.
Thank you for your question. The intronic variant is likely to cause a splice site effect, which means that it acts like a frameshift mutation. It can cause an exon skipping or an exon or an intron inclusion in your transcript, and this is likely to change your messenger RNA and consequently the sequence of amino acids. So it is acting, it functions like a frame shift mutation, okay, and can result in truncated protein. Okay, so it is at a genetic effect. It's not an epigenetic, because maybe at the end of the day, yes, the protein expression will be affected, but it is from a primary genetic defect. This is part one of your question. Now, the second part of your question is how are you going to use this for pre-symptomatic treatment? You are absolutely right. We need to know the pathogenesis and what is triggering the disease in order to manipulate this pathway and stop it from happening. And that is why we're going to be integrating the work with Dr. Abdallah and understand this further. And this is why the clinical trials are ongoing. Some trials were using the calcium channel blockers because of the hyperexcitability in the myocardium of hypertrophic cardiomyopathy, myocardial fibrils. So you are right. We have still a lot to do and to work on, and it's not an easy job. Thank you for your question.
For your question, actually, it's an excellent question, but we still, early in the stage of proving the concept. You can't imagine, the importance of ACE inhibitors in cardiology. They fight fibrosis. We give it to all MI patients, post-MI patients. But the link between endothelial mesenchymal transitions and ACE inhibitor was not established yet. We're looking for something like that, because ACE inhibitors is an effective drug, but EMT is a new theory. We want to link both of them. Is the ACE inhibitor responsible in part for preventing some of the pathways like the SMADs or snails, any of these transcriptional factors in between? Could be, which I think it's a good theory. So, we're still early in this phase. These are very good questions. We are trying to answer all of it. But we found this. The TGF-beta pathway is the main pathway. TGF-beta, it's a huge family, and we're trying, to deal with all of these transcriptional factors. We are focusing on some of them, but of course we need other groups to work on that to find if we stop that transcriptional factor, if we promote these transcriptional factors. But what we are doing now, we're just inhibiting these pathways. We are not promoting this to have a tumor. We are not it's different from stem cells. Stem cells is a good thing, but I personally worked on stem cells for maybe 2 years, back in 2005 in the United States. But unfortunately, the US government stopped our project because we have 2 patients who developed blindness, and they shut down the program at that time. But now, they are encouraging more stem cells program. But what I'm telling you, it's a new theory. We are working on that, and I hope we can find a good answer to your questions. Thank you.
We are going to close with Alistair's comments.
Thank you. Yes, I think you raise a very important point about prevention. Prevention is normally better than cure in all circumstances. The difficulty we have with the state of knowledge at the moment is assessing the degree of certainty that is the point at which it becomes appropriate to make an intervention. In understanding the relationship between our genotype and our phenotype, there are some things which we can be very confident about. There are some single gene disorders where you see the mutation, you can spot the effect. With complex diseases, we're much further away from that certainty. But I think with the development of the sort of high-quality research that we've heard about from our speakers, the sort of initiatives that are happening here in Egypt, then, we are poised to have a really significant step forward in the opportunity to intervene. But that requires the sustained effort, the sustained investment of all of us working together towards that common goal, so that we can understand the link between the detection of genetic changes in the genotype and the emergence of ill effects in the phenotype. and we can target the interventions from amongst the range of possibilities that might be open to us to ensure that we fulfill that basic precept of medicine. First, do no harm, but secondly, also to try and do the maximum amount of good for those who otherwise would suffer from harms which might otherwise have proved to be avoidable. And that seems to me like a good goal to aspire to. Thank you.
Well, I think that both the panel and the audience, they deserve a resounding applause, don't you think? Thank you very much.